Uh, we're going to talk about corneal dystrophies. We have to know that dystrophies are rare conditions, and they often have an autosomal inheritance. They vary in frequency and expressiveness. Most of dystrophies slowly progress with onset by age. Most are not associated with systemic or ocular disease. Dystrophies usually are bilateral and may vary in severity. They usually have a central location and primarily involve a single corneal layer. So there are dystrophies and there are corneal degenerations. Degenerations are rarely found to have a family history or a genetic disposition. You commonly are associated with systemic disease, like something like rheumatoid arthritis, syphilis, Crohn's disease. They're usually asymmetric. The right eye is not like the left eye, and often peripheral, while dystrophies may be involve the central cornea. An example of degenerations are arcus senilis, Vogt Limburger-Gödel, Salzmann nodular corneal degeneration, climatic corneal droplet corneal dystrophy, and keratoconus. So also degenerations, in addition to being asymmetric, they commonly have corneal vascularization. Unlike most of corneal dystrophies. Can you please confirm that you're hearing? Can you please confirm that you can hear? So corneal dystrophies have clinical diagnostic definitions. We first have to remember that the cornea is 5 layers: epithelium, basement membrane, Bowman's layer, corneal stroma, Descemet's membrane, and endothelium. So historically, there was the corneal dystrophies were classified according to the layer they most involve. Like Rees-Buckler corneal dystrophy or Thiel-Beck corneal dystrophy involve Bowman's stromal corneal dystrophies who years ago developed the classification of corneal dystrophies, and they divided corneal dystrophies according to 4 categories. That the disease is well characterized, and they divided them into epithelial and subepithelial, epithelial, stromal, and endothelial. Starting with epithelial dystrophies, there is the most common diagnosed dystrophy has been called Cogan epithelial membrane dystrophy. It is tricky. It has a variable appearance, which leads to misdiagnosis. It is sporadic and rarely autosomal dominant with incomplete penetrance. So how does it present? It can present with blurring of vision or attacks of pain and tearing. When they present to you, at the clinic, you will see on using the slit lamp dots, microcyst fingerprints, map-like patterns, isolated or combined. And if you follow up the patient, the picture, the clinical pattern may change over time. The map is, you feel, when using the high magnification, you can think that the map is subepithelial with surrounding faint haze. Epithelial lesions associated, sometimes lattice dystrophy has epithelial lesions. However, and you can think that these epithelial lesions are herpetic but they lack terminal bulbs and elevated borders. So, because the treatment of recurrent erosions is totally different from herpetic keratitis, it is essential to diagnose the process. So the first quiz is, what is the most common corneal dystrophy you'll meet? What is the most common corneal dystrophy you'll meet or you'll see in your clinic? Please either say the answer or write it and send it. What is the most common corneal dystrophy you'll meet? So what can you see here? We see, do you recognize some abnormality which seems to be like maps with slightly hazy border? And if you do slit beam, you'll see that this is in the epithelium and basement membrane. Here, this patient had reported by Ku and et al. Had attacks of recurrent corneal erosions, bilateral, and the doctor debrided the epithelium to let a new healthy epithelium heal. So as you can see, the debrided epithelium has changes, like ectopic basement membrane inside the epithelium. Abnormal parts of the base membrane curled or inside the epithelium, and sometimes there are cysts. And as you can see before the debridement with the optical coherence, anterior segment optical coherence tomography, there is an hyper-reflective elevation associated with undulation and elevation of the corneal epithelial layer. Even having a shadow. Here you can see there is a posterior shadow because of this hyper-reflective layer. After debridement, 2 years after the debridement, the condition is much better. So here is pathology. You see intraepithelial cyst and ectopic basement membrane. This can, several disorders can have this picture. And this slide, this section or tissue was stained by periodic acid shift. Here we see this normal basement membrane. Here is the ectopic basement membrane with cysts. Here again, ectopic basement membrane, cysts. Some call it map dot fingerprint corneal dystrophy. Some debate that this is not a corneal dystrophy. Then, because of the recurrent erosions, what is the main complaint, you would think? The main complaint may be blurring of vision. Why? Because there are some optical aberrations that happen, and the patient may suffer from something like regular astigmatism. And then there are the recurrent corneal erosions, which can be treated medically by lubricants, tear substitutes, can be treated by epithelial debridement, polishing of epithelium with means of photoablation. So when we treat, we don't exceed 10 microns in depth, optical zone, and give a chance for the normal epithelium to heal again. The second corneal epithelial basement membrane corneal dystrophy is Meesmann. It is very rare. It is usually non-progressive. So when we say here non-progressive, so diagnosis of corneal dystrophies may need the doctor to have a diagnosis, to see the patient several times. and maybe even he may need to examine family members. So it might come by time to diagnose corneal dystrophy. They're rare conditions. Uh, I'm not very good at that, but it needs uh, a clinical sheet documentation of what you see in the patient. And when follow up, you can get out this patient sheet, and then time after time by examining the patient, you realize that this patient has a corneal dystrophy. The Meesmann epithelial dystrophy said is non-progressive. There is a disorder in the corneal epithelial keratins. It's maybe metabolic defect due to encoding gene defect. It is autosomal dominant. The clinical picture is variable with ocular irritation in early infancy, and there are many small intraepithelial cysts, uniform in size, maximal at center, not reaching the limbus. There might be slight thinning of the cornea, and there might be some reduced sensation. So it's very rare, non-progressive corneal epithelial keratins, metabolic defect, autosomal dominant, clinical picture is variable, many small interepithelial cysts, uniform in size, maximal at center, not in limbus, slight thinning of the cornea, reduced sensation. Here is using retroillumination against a dilated pupil, and here are the interepithelial cysts. The pathology shows abnormal corneal epithelium with intracytoplasmic cyst-like inclusions. Abnormal epithelium with these inclusions. By hematoxin eosine, when stained by periodic acid, you find positive staining. It is diastase sensitive. There is this material within the cells. Transmission electron microscopy shows clusters of electrodense fibrogranular material within a degenerated epithelial cell. Electrodense. So the treatment of Meesmann dystrophy is lubricants in vast majority. This epithelial dystrophy has also something like world configuration with gray bands of densely packed microcysts on retroillumination. It is autosomal dominant or X-linked dominant. The locus has been localized to X chromosome, short arm 22.3, proved in some. The diagnosis is usually accidental, and the treatment is hard contact lens if the patient accepts that. So going on to the next corneal dystrophy is the subepithelial mucinous corneal dystrophy, which has autosomal inheritance. So it appears like these lesions in the subepithelial layer, which may involve the corneal center. On histopathology using Mason trichrome stain, there is a subepithelial mucoid material stains with lighter green. So here is the epithelium, here is the subepithelial mucoid material, here is the Bowman membrane. Using transmission electron microscopy, we show relatively lucent area with fine filaments adjacent to collagen fibers. So here is a table showing the dystrophy and the classes, the epithelial, subepithelial dystrophy, epithelial basement membrane dystrophy, epithelial recurrent erosions, subepithelial mucin dystrophy. So the most common dystrophy that we'll see is mostly sporadic. The others are mostly autosomal dominant, with the exception of leash epithelial dystrophy, which is X-linked dominant, and the gelatinous drop-like corneal dystrophy is autosomal recessive. Here are the genes, and some relate these dystrophies to transforming growth factor beta in minority of cases. Here are the Bowman's layer dystrophies: Rees-Buckler, Thiel-Benck, Grayson-Willbrand, and all are autosomal dominant. Here is the gene location, and also some are related to transforming growth factor beta. The stromal dystrophies like lattice type 1, granular type 1, macular corneal dystrophy, Schneider congenital corneal dystrophy, Fleck corneal dystrophy. As you see, all are autosomal dominant except macular, which is autosomal recessive. The genes have been located except for posterior amorphous corneal dystrophy and central crowded dystrophy Francois, or the pre-Descemet's corneal dystrophy. So if all these are categorized, then it is International Corneal Dystrophy 1, which has clinically is well defined. The gene locus is known. Even the gene product can be known. And some are, if there's something missing, some piece of information missing, then the category decreases. So Descemet's membrane dystrophies, like Fuchs or Fuchs endothelial corneal dystrophy, which some divide into late onset, early onset, posterior polymorphous corneal dystrophy, posterior type 1, type 2, type 3, congenital hereditary endothelial dystrophy type 1, X-linked endothelial dystrophy. As see, also most are autosomal dominant except the X-linked endothelial dystrophy. Returning the Bowman's layer anterior stromal dystrophy, they most are autosomal dominant. Like honeycomb dystrophy or central calcine dystrophy of Schneider. In these, there is Bowman's membrane replacement. It is subepithelial. It might have a clinical picture of severe recurrent corneal erosions under the age of 20. Most changes are done centrally, increase with age. With reticular collagen deposition, there is visual impairment. There might be decreased corneal sensation and gray, white, fine, round, and polygonal lesions. Then there is the Rees buccal corneal dystrophy, in which there is destruction. So the first one is described as honeycomb corneal dystrophy. Honeycomb corneal dystrophy. It many different. Yeah, it is common for dystrophies, corneal dystrophy, to recur after corneal transplantation. Rees buccal corneal dystrophy, there is destruction of Bowman's membrane and irregular epithelium. And on Mason trichrome, there may be deposition of mutated transforming growth factor beta induced protein in the anterior stroma. And here is the OCT image showing the hyperreflective lesions and material. The treatment of Rees buccal corneal dystrophy is lubricants for recurrent corneal erosions. Some doctors tried phototherapeutic keratectomy. Here is the steel bank corneal dystrophy. This is the clinical picture you might see. It's also called the corneal dystrophy of Bowman layer type 2. Autosomal dominant on gene 10, long arm, the gene 4 transforming growth factor beta 1. There is recurrent corneal erosions at the ends of the first decade. The visual impairment is less than Rees buccal. There are central subepithelial honeycomb opacities. So comparing the two dystrophies, this is comparison of dystrophies, and here we can see something called like the sawtooth pattern and destruction of Bowman's membrane, where here there is deposition of this material in the anterior stroma. So here is again the thickening of the epithelial layer and Bowman's layer, and it's replaced by fibrocellular material in a sawtooth pattern, which from the point of view of pathology is pathognomonic. On electron microscopy, there are curly fibers that distinguish the steel bank from Rees buccal, and here is the anterior segment OCT. So moving forward to stromal dystrophies, most are autosomal dominant. A number have the gene defect either at the chromosome 5, long arm point locus 31, or chromosome 9. The two autosomal recessive ones are gelatinous and macular dystrophy, and these are the chromosomes associated with them. So what is TGF beta 1? TGF beta 1 is located on chromosome 5q30 locus 31 and codes for keratoepithelium, which is a protein secreted by corneal epithelium. This protein acts as an adhesion protein and is present in normal stroma. Being a small protein size of the albumin, it has the capability to diffuse through corneal stroma. When there is a mutation, the keratoepithelium structure is abnormal and accumulation of the insoluble protein or its proteolytic fragments occur in the cornea. So here is the chromosome. So it's located on the long arm of chromosome 5 at position 31, as you can see, which is associated with the TGF beta 1. There are several mutations in TGF beta 1 associated with more than one corneal dystrophy. So again, this transforming growth factor beta induced is a 68 kilodalton protein. Locus and the TGF beta gene locus chromosome 5 long arm position 31. So it binds to type 1 and 2 and 4 collagen, and it is found in extracellular matrix and serves the adhesion protein ligand recognition sequence for several integrins and plays a role in cell collagen interactions. And maybe in other parts of the body also. So here is the normal TGF beta 1 structure. Moving forward to other stromal corneal dystrophies, there is the lattice corneal dystrophy type 1. It is also autosomal dominant inheritance related to TGF beta 1, also located at the chromosome 5, long arm, position 31. It has an onset near the age of 10, so young child. The recurrent choroidal erosions may precede stromal signs. So as we see here, we might not be able to diagnose the case except with good documentation, follow-up of the patient. On retroillumination, you can see these refractile dots that coalesce into lines are anterior stromal. Here is on the slit beam illumination. Usually the type 1, this fine lattice, with deep and outward spread and do not reach periphery and with diffuse stromal haze, and the corneal sensation may be decreased. On histopathology with hematoxin is seen, there is these pink amorphous deposits in the stroma. Higher magnification of these pink amorphous stones with Congo red stain, they stain as if they're amyloid. So lattice type 2, which has some other names and may be associated as an exception of corneal dystrophies with systemic findings like amyloid cranial neuropathy. It is autosomal dominant. It has been located to or associated with chromosome 9, long arm, position 34. and the onset is usually between the age of 10 and 20 years, and recurrent corneal erosions are rare in lattice type 2. So they are common in lattice type 1, and they may precede other corneal findings. But in lattice type 2, they are rare. The lattice type 1 is fine outward lattice. Here is random short fine lattice, sparse thin, more radial, more peripheral, and there is decreased corneal sensation. So here is a clinical picture of advanced lattice corneal dystrophy, showing these fine refractile on maybe this is oblique or sclerotic scatter illumination. So clinically, here's the corneal findings of this lattice, and here is the systemic cranial neuropathy, mask face, maybe ears are have this configuration. The patient may have, due to amyloidosis, facial paralysis, which may be bilateral. And this patient had a tarsorrhaphy done for him with this exposure keratopathy. There may be complications. So some respected may regard it as not a dystrophy, but a systemic amyloidosis. So it can be associated with open dermatochalasis, with open angle glaucoma, facial paralysis, bilateral changes in the skin fragility with ecchymosis, mask face, hair loss, dry skin, bilateral carpal tunnel syndrome, nephrotic syndrome, cardiomyopathy, cardiac conduction defects. So how would we treat this? This patient was treated with this gold weight to decrease exposure keratopathy. And a lower lid with a cartilage graft called SCAFA cartilage graft to support the lower eyelid. This patient had this syndrome, bilateral facial palsy, skin changes as you see, cannot close her eyelids. Then after surgery, with this gold weight and the SCAFA cartilage graft for lower lid, she can close her eyes. So again, this same progressive bilateral cranial peripheral neuropathy, dysarthria, skin manifestations, dry, very lax, itchy, protruding lips, pendulous tears, kidney and heart affection by amyloidosis, mask face. Treatment follow-up, very difficult keratoplasty because of this exposure and facial palsy, not easy. So there is lattice type 3, which occurs in old age, 70 years, 90 years. Also, the dominant associated with TGF1 with thick rope-like bands on retroillumination. Moving forward, There is this gelatinous drop-like dystrophy. Um, it is rare. It is autosomal recessive. It has been localized to chromosome 1, short arm, position 32. For some reason, it is more recognized and more diagnosed in Japan from very infant, young infant to 20 years with photophobia, tearing, decreased visual acuity. This is like the advanced kumquat, which is a fruit uh, like a small orange or something like that. And it is recurs in corneal grafts. So here, this patient had a corneal transplantation, and the dystrophy recurred in the graft. Can be described like mulberry-like. So here is the gelatinous drop-like corneal dystrophy with stained by hematoxin and eosine, and shows the amyloid deposits. So, any questions till now, please? Are you still awake? Are you still awake?
معاك يا دكتور شكرا.
So,
مع حضرتك يا دكتور شكرا.
so quiz number 2. Quiz number 1. We'll repeat quiz number. What is the most common corneal dystrophy that you will encounter the most common corneal dystrophy that you will encounter? Giving you a clue, it is corneal dystrophies are categorized according to the layer of the cornea effect. So it affects the superficial layer. Clue number 2, it is usually sporadic. Clue number 3, it is variable in picture. You can see the patient with a picture today or tonight, and then when you follow the patient up, you find the lesions have changed in shape. Any one would like to tell us? Quiz number 2 is what is the stromal corneal dystrophy bet between two brackets, because some might say it's not a corneal dystrophy, it's a systemic disease that has cranial polyneuropathy, can have muff, face, facial palsy, pendulous ears, dry, thin skin. So moving forward, With stromal dystrophies, there is this granular type 1, granular corneal dystrophy type 1, which is also dominant, also related, has been related to chromosome 5, long arm, position 31. It may start at very young age, usually before 10 years pass. The recurrent corneal lesions are uncommon. You can see a radial disc-shaped Christmas tree, small white, sharply demarcated crumbs like when the bread dries and it crumbs. Granules, rings, snowflakes. The stroma in between is clear. Later, there may be haze, and the corneal sensation may be decreased. So this is the theoretical description. What about clinical? So here the rings, breadcrumb-like Christmas tree. Early the stroma is clear. Late there's stromal haze in between the lesions. Here is diffuse illumination. Here is slit beam illumination. Recurrent coronal rays are not that common. If the patient had a penetrating keratoplasty and the corneal tissue was taken for histopathology, so this material stains bright red using Mason transchrome within the stroma here, or with hematoxin eosine is a feeling rock candy-like. Rock candy-like is like the large crystals of sugar. So rod-shaped bodies in the corneal stroma seen by transmission electron microscopy. So here is a comparison between corneal dystrophy type 1, type 2, granular corneal dystrophy type 1, type 2, and lattice corneal dystrophy. Hyaline formations in granular corneal dystrophy within the stroma. In type 2, there is both hyaline and amyloid, and in lattice, there is amyloid. The treatment of granular corneal dystrophy, so there is two issues. If the patient suffers from recurrent corneal erosion, he may require debridement or phototherapeutic keratectomy, epithelial debridement or polishing or phototherapeutic keratectomy. And we limit, as you say, when treating recurrent corneal erosion, usually limit our treatment depths to 10 microns. The condition, as we say, the stroma may become unclear, hazy by the fifth decade, so the patient may need a deep anterior lamellar keratoplasty. So early might not need treatment, but late, if the vision is much decreased, may need either phototherapy or polishing of the cornea, phototherapeutic keratectomy, or anterior lamellar keratoplasty. Granular corneal dystrophy type 2 is which may be called combined granular lattice, but also localized to autosomal dominant to chromosome 5, long arm, position 31. Usually the onset is later in the second decade and is usually accidentally diagnosed. So again, we see to diagnose corneal dystrophy, you might need to see the patient several times, good documentation. You might need to see family members to make sure. If you suspect patient who has recurrent corneal erosion, you might need to see the other family members because this is autosomal dominant. Mild symptoms with recurrent corneal erosions. On examination, their superficial fine passages, ring-like, disc-like, star-like, snowflake-like, Christmas tree-like. They're most centrally most dense, and with the combined granular lattice, there are deeper linear opacities. Here is split illumination of a case. If you are lucky to get a pathology specimen and stain with Congo red stain, they'll show pink amorphous amyloid stromal deposits. There are several reports about, we say corneal dystrophy might have some irregular astigmatism, blurred vision, so and may be associated with refractive error. So if the doctor is refractive surgery friendly and treats one of these cases, there are several reports that the patients who were treated for laser refractive surgery had rapid advanced deposition of the granular deposits and ended up in a less privileged situation than what it started with. And here are some resource exacerbation of Avellino corneal dystrophy after LASIK, several reports. And corneal haze after this. Here is unoperated eye, 7 years after post-LASIK. Age 34. This patient, female, age 25. Patient is 34, 3 years after post-LASIK. So even a company or there was like a proposition that before LASIK if the patient has any corneal opacity to do a test in which DNA is analyzed for 5 transforming growth factor beta 1 gene, which can diagnose 5 corneal dystrophies, granular corneal dystrophy type 1, granular corneal dystrophy type 2, lattice corneal dystrophy type 1, Thiel-Benke corneal dystrophy, Buckler corneal dystrophy, which are all associated with TGF beta 1, with a swab from the inside of the mouth, which may diagnose 5 types of corneal dystrophy. Also, the corneal dystrophy, this gene defect may be homozygote or heterozygote. Obviously, homozygote may progress faster than heterozygote. This is a theory. Macular dystrophy. This is a patient from outpatient clinic at Ain Shams Department of Ophthalmology. Not very good. Here's the lower lid, cornea here, the iris, there's a corneal haziness, and there, if we can imagine with me that there are macular lesions like this one. It is the least common stromal dystrophy. It's autosomal recessive. It has been localized to chromosome 16, long arm, position 22. And it is a local corneal manifestation of an inborn error metabolism of keratan sulfate. the acuity is decreased at a young age, and the stromal haze serves as the center. The lesions may be from limbus to limbus and may involve anterior and posterior stroma till the periphery. It is unusual for recurrent erosions to happen. However, the surface is irregular, and by time the size and the haze increases to become full thickness limbus to limbus, and there might be some corneal thinning. Early, granular, with macular dystrophy, note that the anterior stromal deposits and Bowman layer disruption. Anterior stromal deposits and Bowman layer disruption. With Alcian blue stain, you can identify mucopolysaccharide deposits within keratocytes highlighted with Alcian blue stain. Treatment: penetrating keratoplasty. However, recurrence may happen. So here is a comparison between some dystrophies. What is there is here this stromal dystrophy? So autosomal dominant. What is dystrophy is autosomal recessive? The third quiz. Two dystrophies, gelatinous and macular dystrophy, are autosomal recessive. So here, this autosomal recessive is very rare, but it can appear in early in age. Erosions we can this table is like a mindset to diagnose the dystrophy. You think about what? So when you see a corneal dystrophy, especially stroma, you think of age of onset, how old, is their family members affected, is there reduced vision, are there a history of erosions, common, uncommon, frequent, are the cornea, the opacity, the lesions in the cornea have clear stroma in between or indistinct margins with stroma hazy and extends to the limbus? Are there lines or breadcrumb-like or macular lesions or dots? Is the limbus, is the cornea, peripheral cornea affected or not? Moving forward, another corneal dystrophy is crystalline Schneider corneal dystrophy. This is an advanced case. We see there's like arcus senilis, and then there is this central lesion. So also this case, here is the case, another crystalline corneal dystrophy with the arcus senilis. There are central opacities and or crystals. and you check for visual acuity, corneal sensation, and central opacity, advancing with time or not, with follow-up. So what are this Schneider crystalline corneal dystrophy? It is the defective gene is called UBIAD1. What is that? The normal cell, the cholesterol metabolism mevalonate is metabolized into FPP, and then either to squalene or GGPP, squalene into cholesterol, or GGP into MK4 or another product. This is normal. It is so the UBIAD1 gene product is a prenyl transferase that uses GGPP to prenylate compounds for formation of MK4 and CoQ10. MK4 is needed for endothelial cell development in a variety of tissues, and CoQ10 is a component of Golgi and mitochondrial membranes, playing an antioxidant role. To mutated cells, the gene diminishes prenylation mainly in the formation of MK4 and CoQ10. Ocular features include corneal dystrophy and accumulation of crystals containing cholesterol and phospholipids. That likely rely to decreased use of GGPP for prenylation. Systemically, the patients may have hypercholesterolemia and hyperlipidemia. So crystalline corneal dystrophy, if you are lucky enough to get a pathological specimen and stain it with oil red O stain, which highlights cholesterol crystals which appear red. And with birefringent microscopy, cholesterol crystals are evident in superficial stroma of frozen cornea examined under polarized light. Here by transmission electron microscopy and photography shows numerous electrolucent spaces in the cornea caused by dissolved crystal. So several systemic abnormalities may affect lipid metabolism and result in central corneal cloud, which include fish-eye disease, lecithin cholesterol acyltransferase deficiency, Tangier disease. Diseases with corneal crystals include the following: cystinosis, dysproteinemias, hyperuricemia, multiple myeloma, porphyria, and primary or secondary lipid keratopathy. So these are the differential diagnosis of this Schneider. So quiz number 4, what does Congo red stain? You can don't Concentrate on the answer written before under the question. What does Congo red stain? What Alcian blue stains? What does Mason trichrome stain? So here is Schneider corneal dystrophy again. Early, late. Again. But reminder of the chromosomes in a table, the chromosomes that are related to corneal dystrophy. Moving forward in stromal corneal dystrophy, there is a central cloudy dystrophy of Francois, which is dominant dominant with opacities which are polygonal, cloudy, gray, clear between prominent center, leather-like appearance, clinical picture similar to posterior crocodile shagreen. If you need a break, a 5-minute break or something, please tell me. If you're awake and need a 5 or 10-minute break, please tell me. So there is one of the corneal findings that you can see is called posterior crocodile shagreen. So this is similar to central corneal cloudy dystrophy of Francois, which has polygonal cloudy gray clear in between prominent central leather-like appearance and autosomal dominant. So you can see family members and check. So here's the slip beam showing something like crocodile shagreen, polygonal with clear in between. Here's the same pattern, the same. So flex, corneal flex, here are corneal flex. Corneal flex, slip beam, retro illumination. Moving forward with the stromal dystrophy, there is a congenital stromal dystrophy. Child is born with this dystrophy. And then moving forward, there to the endothelial dystrophies. So the three main dystrophies you might mention are Fuchs endothelial corneal dystrophy, posterior polymorphous dystrophy, congenital hereditary endothelial dystrophy. So some divided Fuchs into two types, early onset and late onset. However, it is in old age, the majority. The majority are sporadic. Some show autosomal dominant inheritance, slowly progressive. There is cornea guttata with beaten metal endothelial decompensation, bullous keratopathy, and there might be melanin. The root cause of this condition is slowly progressive formation of guttata lesions between corneal endothelium and the descending membrane. These wart-like anvil-shaped or mushroom-shaped excrescescence are said to be abnormal elaborations of basement membrane and fibrillary collagen by distressed or dystrophic endothelial cells. As the lesion enlarges, the covering endothelial cell initially becomes stretched and then eventually fall off. So here is examine corneal guttata. Can use confocal microscopy or specular microscopy. Beaten metal, there is the guttata with endothelial cell loss, protrusions, and then as the case advances, there may be corneal stromal edema, striate keratopathy, and the corneal may exceed 630 microns in thickness. Here with scan specular microscopy, there is tiny dark spots. Fox endothelial view of gupta on inner surface of the cornea by scan electron microscopy. Here is hematoxin is seen stain showing the gupta here in the endothelium with loss of endothelium. Adjacent coronal stroma shows also the gupta. There is few endothelial cells and some containing melanosomes. Again, a picture of Fox endothelium. This here you see that there is subepithelial fluid cyst due to corneal edema. Endothelial cell closely adherent to a collagen layer with fibrils contain oriented in different directions. What is the theory of Fox endothelial corneal dystrophy? Prophylactic before. Its importance, if the cornea is not more than 30% thick, it's okay. However, if the patient has an ascitic cataract and needs to be removed, then you have to check for this corneal cataract and fix endothelial dystrophy and to take the required precautions, especially if the corneal stromal thickness is more than 640 microns. So what are the precautions? The choice of viscoelastic, the amount of intraocular fluid, irrigating fluid, the type of intraocular lens. Will you do intraocular lens extraction with intraocular lens implantation or with or without keratoplasty? In cases, the follow-up of surgery may include 5% sodium chloride drops or ointment, decreasing the intraocular pressure, exposure to warm air. Soft bandage contact lens. If there is corneal edema, the choices either are Desmond's layer endothelial keratoplasty or penetrating keratoplasty. Corneal edema, as you see, with this corneal guttata appearance of the Desmond membrane. So what is posterior polymorphosis different? Moving on, it is rare. There are three forms. Usually asymptomatic, usually autosomal dominant, starts early in the neonatal period. However, the discovery is usually accident. There are vesicular endothelial lesions which may become confluent into band-like or diffuse opacities which may be asymmetrical. Here, as we see, this is this membrane, and this endothelium becomes multi-stratified, like stratified squamous epithelium with periodic acid shift. If you have lucky to have a tissue specimen and do scanning electron micrograph, you will see numerous microvilli on the surface of the corneal endothelial cell. Associations with posterior polymorphous dystrophy are iris abnormalities, glaucoma, and Alport syndrome. Treatment not required. Moving on, there is congenital hereditary endothelial dystrophy, which is rare, focal, generalized absence of endothelium. Two main forms, type 1, type 2, have been associated with being autosomal dominant with chromosome 20 short arm location 222 or the long arm location 11.2 with congenital hereditary endothelial dystrophy type 1. with the autosomal recessive, it has been associated to chromosome 20, short arm, location 13, with type 2, congenital hereditary endothelial dystrophy. As you see the child here, and the cornea seems so hazy, however, the vision might be even blue-gray ground glass appearance with total opacification, bilateral symmetrical diffuse corneal edema. The vision, sometimes the child may be lucky with have ambulatory vision. What is the differential diagnosis? Any cause of neonatal corneal opacification like ophthalmos, mucopolysaccharidosis, birth trauma, rubella, sclerocorn. If you were lucky enough to get a corneal specimen, you'll see that the endothelium is markedly biculated. There are no guttat. Lumen layers is destroyed. Here on the right, there is transmission electron micrograph of this membrane and the corneal endothelium. With haphazardly arranged broad-banded collagen fibers within this membrane. Treatment, if needed visually, there might be, it's technically difficult because any keratoplasty under the age of 9 years old is not that easy. And the problem is if you treat early, penetrative keratoplasty is technically difficult. Issues of rejection. If you delay treatment, the child might develop dense amblyopia. Quiz 5. What are these? What is this? What is this type of examination? This is not ophthalmology medicine examination, but granular dystrophy seen by Mason trichrome, macular dystrophy with Alcian blue for glycosaminoglycans, colloid iron, lattice with Mason trichrome, proteotic acid stitch, Congo red, birefringence, granular lattice with Mason, proteotic acid stitch, amyloid Congo red, birefringence. Few of the corneal dystrophies may have systemic features. Two of them are the lattice type 2, which has systemic amyloidosis, or the Schneider corneal dystrophy might have with crystalline deposits. The patients may have hypercholesteremia, hyperlipidemia, genovalgum. Electromicrograph or congenital stromal dystrophy, showing normal collagen lamella separated by abnormal randomly distributed collagen filaments. What are the differential diagnoses of corneal dystrophy? Some of the degenerations, like lipoid degeneration. So lipoid degeneration may be associated with herpes simplex keratitis, It can be vascular, it shows vascularization, it says degeneration. Show there is the arcus senilis, voct limbar girdle here. Recurrent corneal erosions. There is the differential diagnosis of crystalline deposits in the cornea, like hyperuricemia, stenosis, multiple myeloma, this proteinemias. There is the keratoconus, which has its peculiar picture because it might present after hydrops with corneal opacity. Keratoconus may present after hydrops with corneal opacity and flattening of the cornea, thinning and flattening of the cornea. Any questions, please? Any questions? Fatty degeneration, في band keratopathy, may be mixed up with one of the pictures of gelatinous corneal dystrophy, which occurs more in Japanese and may have a mulberry-like appearance or kumquat fruit appearance, may be like band keratopathy. But band keratopathy may have superficial opacification with calcium deposits with clear area at the nerves. Choroid degeneration or Labrador keratopathy. Salzman nodular degeneration. Any questions, please? Are you still awake?
مع حضرتك يا دكتور.
Any question? أي أسئلة؟ من
شكرا.
فضلكم أرجوك. هنا في الريفرنسز for further reading يعني. Yeah, if there are any questions, please contact me through email, please, or phone number. And Happy New Year. Any questions, please?
شاكرين جدا لحضرتك.
متشكر جدا ليكم، وإن شاء الله نتقابل في يعني ظروف أفضل.